Hi, everyone. Today I would like to discuss about calcium disorders in pediatrics and also about rickets. So this is the last video lecture for the lecture series for the academic half day. So we will review this topic on April 29th. So I hope you all have a chance to review this before the session. So calcium homeostasis is probably one of the least favorite topics for many of you because you often find it to be very confusing. And the reason for it to be so confusing because there are many players in the calcium regulations. As for endocrine system, the most important gland that has a central role in calcium homeostasis is parathyroid gland. So first, let's review the calcium homeostasis. So when serum calcium drops, it will directly stimulate parathyroid gland to stimulate parathyroid hormones. So parathyroid hormone itself has three main sites of action. Number one is in the bones, which it stimulates bone resorptions to the stimulation of osteoclasts, causing an immediate release of calcium into the bloodstream. Parathyroid also stimulate calcium reabsorption in the kidneys and also excretion of phosphorus, which we call phosphaturia in the kidneys. And it also stimulates calcium absorption from the small intestines. Once serum calcium level is restored, the calcium itself would act as a negative feedback to suppress parathyroid hormone secretion in the parathyroid gland, completing the loop. So I like you to think of this as a feedback loop that we talked about it in other glands, except that the calcium itself is the negative feedback loop. So PTH actions also in the kidneys and intestines are also related. So when PTH is secreted, it stimulates a production of 125 dihydroxyvitamin D or calcitriol, which is an active vitamin D. This action is also stimulated by PTH. So calcitriol also increased calcium absorption. Is actually one of the most important factors for calcium absorption in the small intestines. So we have to also discuss about vitamin D metabolism, which is also another important player in calcium homeostasis. So the plain vitamin D that we take as a supplement is ergocalciferol or cholecalciferol. So the body can actually synthesize cholecalciferol. So after the body produces cholecalciferol or you take vitamin D supplement, it gets converted to 25 hydroxyvitamin D in the liver. So 25 hydroxyvitamin D then gets converted to 125 dihydroxyvitamin D or calcitriol in the kidneys. So we now have all the players that are important in the calcium homeostasis. So there's one thing that I like to stress is that hypocalcemia does not always equal to vitamin D deficiency, meaning that not all cases of hypocalcemia is caused by vitamin D deficiency. It's probably the most ordered test in hypocalcemia. We're going to come back and talk about the relationship between vitamin D deficiency and hypocalcemia later. So make sure that you review clinical manifestations of hypocalcemia. So we divide into either newborn groups or childhood and adolescence. So in the newborn period, the newborn infants can present with jitteriness or seizure. But for childhood and adolescent period, they can present with Chauvet-Steck's Trousseau sign, seizure, or alteration of consciousness. So these are the clinical manifestations of hypocalcemia. So when evaluating a patient with hypocalcemia, make sure that you apply the same principles that we talked about. So you want to review the history and perform a detailed physical exam. So in the newborn period, you want to review maternal and perinatal history. right? Because many of you who rotated through NICU already saw that hypocalcemia is such a common problem in the newborn period. The common etiologies of hypocalcemia in the newborns are usually not caused by parathyroid abnormality, but rather the perinatal problem, such as prematurity, small for gestational age, infant of a diabetic mother, or total hypercalcemia or iatrogenic in patients receiving TPN. In children and adolescents, you want to make sure that you review history, onset, especially family history, because many of the parathyroid disorders are genetic conditions. So you want to pay particular attention during the physical exam to the symptoms of hypocalcemia and also EKG changes, which indicate that this hypocalcemia is severe enough to be treated immediately. And for the laboratory, besides other labs that you normally request, you want to determine if this is caused by hypoparathyroidism. So how can you do that? So you can do that by obtaining serum calcium, phosphorus, and PTH during the onset of hypocalcemia. Why? Because in hypoparathyroidism, you will see an inappropriately low PTH for the serum calcium. Remember, this is another condition where the normal level of PTH during the time of hypocalcemia is not normal. Besides hypocalcemia, you would often find elevated phosphorus level in hypoparathyroidism. Why? Because of the lack of PTH action of phosphate excretion. You may also see an inappropriately low 125 dihydroxyvitamin D, but this is not as important as the serum calcium and phosphorus itself. So what are the etiologies of hypoparathyroidism? So there are three main categories. Congenital, you can have a syndrome that causes an absence of parathyroid, such as DiGeorge syndrome. Also for trauma, you can have an accidental parathyroidectomy by surgeon. This is often happens in patient who's receiving total thyroidectomy and the surgeon accidentally remove parathyroid gland. Or autoimmunity, such as autoimmune polyglandular syndrome, in which you have autoimmune destruction to many glands, including parathyroid. And also, it can be caused by hypomagnesemia, because magnesium is an important factor for parathyroid secretion. So we often obtain serum magnesium in patients with hypocalcemia as well. So this is a picture of a patient with DiGeorge syndrome. So what is DiGeorge syndrome? So it is a contiguous gene deletion syndrome caused by deletion of 22q11 region. So in this region, there are many genes that are important for the third and fourth pharyngeal arch, right? As you remember from embryology, the third and the fourth pharyngeal arch forms parathyroid, heart, thymus, bilipalatine muscle. So patients with DiGeorge syndrome often have a combination of hypoparathyroidism, congenital heart disorder, and immune deficiency. So there is another condition that I like to review here, which is called pseudohypoparathyroidism. So the name sounds very confusing as well. So what is pseudohypoparathyroidism? So you remember that this is a PTH receptor, right? So it is coupled with the G protein, right? So G protein is a very important secondary messenger system in many endocrine hormone receptors. So what happened in pseudohypoparathyroidism? So you have a mutation in the G protein. So the G protein cannot send the signal in response to the PTH binding to the receptor, causing a resistance to parathyroid hormones. So there are several types of pseudohypoparathyroidism, but the most common type, and a type that you may be asked on the board exam, is type 1A, which is also called Albright hereditary osteodystrophy. So in this condition, besides biochemical findings, which are identical to hypoparathyroidism, patients also have other features such as short stature, short and stubby hands, and short fourth metacarpal bone. So as I mentioned, the biochemical findings are identical to hypoparathyroidism. Patients have hypocalcemia, hypophosphatemia, except that the PTH level is elevated, indicating the state of resistance to PTH. So now let's talk about rickets. So what is rickets? So rickets caused by a defect in mineralization that involves growth plates. And these defects in mineralization cause a characteristic change in radiogram. So the same condition in adults is called osteomalacia. And I want to point it out again that not all rickets are caused by vitamin D deficiency. So these are the characteristic findings on the X-ray. So you see that there are irregularities of metaphyseal regions of the wrist. So let's talk about vitamin D deficiency and hypocalcemia. So vitamin D deficiency can cause a decrease in calcium absorption from intestinal tract. This has to be a severe and prolonged state of vitamin D deficiency. So what happened? You have a compensation by an increase in PTH level. And remember, PTH also has a phosphaturic effect. So an increase in PTH level will result in hypophosphatemia. And eventually hypocalcemia will develop. And remember, it has to be a long-standing and severe vitamin D deficiency. And after you develop hypophosphatemia, hypocalcemia, then the patient will often have rickety changes as well. So one of the common findings in rickets is that they all have hypophosphatemia. So there's different types of rickets, but the types that you want to review for your board exam is vitamin D deficiency and hypophosphatemic rickets. Again, vitamin D deficiency rickets caused by a severe and long-standing vitamin D deficiency. The patient will have elevated alkaline phosphatase. And on the biochemical findings, you see a hypocalcemia, hypophosphatemia, and elevated PTH level. See, this is different from hypoparathyroidism, because in hypoparathyroidism, you would have an elevated phosphorus. This is a reason why I stress the importance of obtaining a full biochemical panels in evaluation of patients with hypocalcemia. Now, hypophosphatemic rickets, it is a genetic condition that caused by phosphate wasting through kidneys. So the patient will have an elevated alkaline phosphatase, characteristic X-ray findings of rickets that have low phosphorus, but they actually have normal calcium and parathyroid because the defect is at the renal phosphate wasting alone. There's no compensatory rise in PTH level in hypophosphatemic rickets. So I think this is all I want to review for now. I hope you enjoy the video and thanks for listening.